request Dr. Mudit TYAGI, because he is also a known figure, national figure in the field of uvea, not just from retina as well. So I request Dr. Mudit TYAGI to also speak on all may not be well in cases of uveitis associated with cataract surgery.
All right, so good afternoon. First of all, let me thank Dr. Srinivas Joshi and the scientific committee for having me here for this talk. Now, I do not do cataract surgeries, but because I do deal with uveitic patients, I do end up referring a lot of these cases to my cataract colleagues, and because of the fact that I also do retinal surgeries, I also end up sometimes taking care of some of the complications that can occur in these cases. So now, what are the indications for doing, first of all, a cataract surgeries in uveitic patients? Now, we must understand that cataract is one of the most common complications of a long-standing chronic or a recurrent uveitis. And it's basically both things. Cataractogenesis occurs because of the inflammation and the uveitis that is there. And cataractogenesis also occurs because of the treatment for uveitis, meaning thereby the steroids that we end up giving to our patients to take care of the cataract. So it's a situation from which there is no escape. You have uveitis, you will develop cataract. You get treated for uveitis, you will develop cataract. It accounts for up to 40% of visual loss in patients with uveitis and is one of the most common indications for surgical intervention in these eyes. Now, overall, if you look at it, uveitic cataracts comprise approximately 1.2% of all cataract surgeries, which may seem minuscule, but if you look at the entire number of surgeries in terms of cataracts being done every year, it's a huge number. And the surgical outcomes are slightly less predictable as compared to a conventional simple cataract surgery that most of our colleagues do. So what are the indications? The first indication for doing a cataract surgery is a lot of times a case where there's an inability to visualize the posterior segment in patients with posterior segment diseases. Now, because the cataract is obscuring your visualization, you do need to get a clear media so as to even understand what's the underlying pathology happening inside the eye. Apart from that, obviously, because of the visual loss that occurs because of a cataract, that's another indication. And sometimes it can be a therapeutic intervention in cases of phacoantigenic uveitis. So what are the challenges that we will face when dealing with uveitic cataracts? There are preoperative factors to be looked for. There is obviously a lack of visualization, small pupils in synechiae, and an unpredictable postoperative course, including an increased incidence of postoperative inflammation in these eyes. So what are the things that as surgeons we should think of in terms of the preoperative management? Remember the 5 A's. Number one, the age of the patient. Obviously, a pediatric cataract will be slightly different as compared to what you do for an adult uveitic cataract. What is the etiology of the underlying uveitis? And we'll deal to that. Most importantly, activity. Is the eye quiet? The rule of thumb ideally is that you should have a quiescent eye for at least 3 months, but if that's not the case, at least for a month. Associated ocular pathologies need to be taken care of, and associated systemic diseases also need to be under control before we proceed with cataract surgeries in these eyes. Now, like I said, look at the etiology. If it's a Fuchs uveitis, the incidence of cataracts is around 50% in these eyes. These eyes do thankfully have a better prognosis. The other important thing is that usually there are no synechiae in eyes with Fuchs and no cystoid macular edema. The one thing which we need to remember while doing a cataract surgery for these uveitic patients is a very important counseling, because of the fact that Fuchs patients will end up having a lot of floaters. Now, because of cataract, a lot of times these patients do not even appreciate them, but once you get a clear media, your patients are going to question you about the floaters which they are now able to perceive better as compared to what they were doing when they had a visual axis obscured by the cataract. So you need to talk to them, counsel them, and explain to them the incidence or more appreciation of floaters post-operatively, unless and until you intend to also do a vitrectomy along with the cataract surgery, which is a different story altogether. Often your cataract may also be confounded by the presence of an underlying vitritis, and those are cases where you need to slightly tread with caution, because you may have an underlying infective uveitis also occurring concurrently. So rule out infections, and ultrasound B scan becomes extremely important in preoperative assessment of these patients. So this was a patient who had a hypopyon and activity, obviously not a candidate for an cataract surgery at this point of time, but the ultrasound was otherwise fine. On the other hand, we have had patients where there was an active toxoplasma and an active uveitis going on, so you need to take care of them. Non-calamitous anti-uveitis, Behçet's, and VK sympathetic ophthalmia are the other etiologies that you need to keep in mind. Essentially, the point is that you should be aware of the etiology of the case that you are handling at this point of time. Look for signs of inflammation. Like I said, it's important to ensure that the eye is quiescent for at least 3 months. So see if there are any anterior chamber cells there. Get a OCT done if you have got a media which is clear enough. So if there is a cystoid macular edema which is persisting, obvious sign of inflammation, probably you need to take care of the inflammation first before you run into a cataract surgery. Though if you have got a very poor media and you need to get a cataract surgery done to visualize the medium, then obviously this rule doesn't count. But otherwise ensure that your eyes are quiescent and there is no CME when you get a pre-op OCT done for this. Counseling, like I said, is extremely important in these cases. There is usually a debate between phaco versus SICS versus actually even a lensectomy in a lot of these patients. And there are studies which have shown that the incidence of postoperative inflammation is not different between SICS as well as a nicely done phacoemulsification. A pars plana lensectomy can sometimes be done in eyes where there are extensive synechia, in eyes with JIA, in eyes where there is hypotonia and ciliary body membranes. Those are eyes which probably may not do well with a conventional cataract surgery, and those are some of the eyes where you may just need to leave the patient AFK. Band shape keratopathy and lack of visualization can be other complications which sometimes do need to be taken care of in these eyes. The other problem sometimes can be a very small pupil or presence of synechia, and then you need to take care of all the other factors which can help you in overcoming these problems, including extensive use of mydriatics, OVDs, pupil stretching, iris hooks and rings. Intraocular lens implants, there are multiple studies which have compared the role of acrylic versus silicone IOLs, and they have shown that hydrophobic tend to cause less inflammation as compared to silicone IOLs in these eyes. The other complication that you need to be worried about is what happens if there is a PC rent or a PC dehiscence. Please avoid iris fixated IOLs and AC IOLs in eyes which have got a past history of uveitis, because you are essentially irritating iris again and probably laying grounds for more persistent chronic inflammation. In terms of post-operative management, do I have some more time?
30 seconds, sir.
Thank you, that's enough. Yeah. So the other incidences and increased incidence of inflammation that does occur in these eyes, and you need to monitor these patients. You will probably need to treat them aggressively. This was a patient post-uveitic cataract, came with extensive inflammation and a hypopyon, but the cornea otherwise was clear. Started on topical steroids, the inflammatory membrane starts retracting, and within a span of 5 days, you've got a clear media, and the membrane goes away. So you need to monitor these eyes well. You need to take care of the protracted and more exaggerated inflammatory response that is likely to occur in eyes with a past history of uveitis as compared to other cataract. So slow taper of topical steroids, slow taper of oral steroids, and if needed, a continuation of the immunosuppressive therapy that these patients may be in. You also need to be aware of the fact that you will have slightly more incidence of macular edema, so keep that in mind. So in a nutshell, good preoperative assessment, take care of intraoperative issues. If you are prepared and aware of the problems you are going to face, then you will be able to tackle them well, and a more meticulous postoperative management are the keys to having a good outcome in these cases. Thank you so much.
Thank you. Thank you, sir.